Thank you, everybody, for being here. I want to thank Dr. Santos for inviting me to give this speaking event. It's my second year, and I've enjoyed this thoroughly. I'm going to shift gears a little bit. I want to thank Dr. Batera for that introduction, Dr. Wong, whom I've known for many years, and a good topic. Optune is certainly an area that we have been using quite a bit and a little bit controversial, but I appreciated that. I'm going to shift gears a little bit, and see if I can move this slide forward. I don't have any conflicts of interest pertaining to these next few slides, at least. I'm always inspired by Harvey Cushing. He's been my mentor for several years, and I feel that one of his slides or one of his famous sayings fits in to our event today very nicely. Especially when we discuss toxicity from therapy. We're all very good about implementing therapies, and we always stay optimistic. We want to cure disease. That's how we were trained. But often it's a secondary thought process that we think about side effects and toxicities. All of us have gotten those phone calls. You start a new experimental drug or radiotherapy or surgery, and you're doing all these amazing things, and then you get a call late night that the patient's having side effects. You're a little bit of a 50-50 conflict. You are certainly a little bit frustrated that you're doing all these amazing things, but the side effects might actually limit your abilities to do it. So I'm going to try to break down complications in very broad strokes into surgical complications, radiotherapy complications, and chemotherapy and experimental trials. Now, everybody can conclude what you may wish from Harvey Cushing's quote, but I feel that Harvey was trying to enlighten us and show us a new world, that we should think about a patient as a whole, not just a patient in our clinics, but what we need to do beyond, and side effects fit into that. Often, most of our world, when we think about neuro-oncology, as all of you know who treat these cases, patient's journey often starts in the emergency room. It's an emergent event. They come in with a new neurodeficits. Let's say it's a new onset seizure, and on an MRI or a neuroimaging study, we find a new diagnosis of a tumor. Often surgeons will take patients in for operations very quickly, which usually is, not always, but usually is something that we want to address very quickly. And I often get these consults intraoperatively or preoperatively or postoperatively. Many times during frozen section, I'll get a phone call from our surgeons, and I'm already thinking about future options, clinical trial options, radiation options, etc. But there's a window there for the next few weeks in which surgical complications are high risk. I saw a case just a few weeks ago. We went up to one of the major academic centers and had a maximal safe resection of a aggressive tumor. And 2 days postoperatively, when the patient followed back in our office, suffered a postoperative hemorrhage. So one of the most immediate complications you need to worry about, not tumor recurrence, but postoperative hemorrhages. Infections are very common, as all of you know, and you want to keep a low index or a high index of suspicion to look for any infections of the wound. I remember being a fellow, and my first year of my fellowship, and I was rounding in the hospital and saw a patient that just wasn't making sense, had radiation, had effective therapies, recent MRI looked overall negative, but the patient's family kept telling me that he's having new neurological deficits. And lo and behold, a month later, when we did another MRI, he had more of a non-obstructive hydrocephalus. So I want to highlight that you want to keep your horizon very broad, and hydrocephalus, mostly communicative hydrocephalus, is not an uncommon entity, and often we feel that it's the postoperative blood and a lot of the postoperative changes. Sometimes it can be tumor recurrence related, of course, but that usually will take several months to happen. Always want to think about essentially hydrocephalus, and it can have very profound complications, very profound symptoms, and if they are picked up quickly, you can also fix them very quickly. Unfortunately, in our world, hypercoagulability is very common, and And most data has shown in high-grade gliomas, about 55 to 65% of our patients within 2 years of treatment will develop a DVT. So hypercoagulability is a big issue. I remember when I was training, we used to talk about it, but we didn't really used to talk about it. That there's a lot more enthusiasm within the academic world to address essentially DVTs and that hypercoagulability risk. We also very commonly have other abnormalities and sodium abnormalities, SIADH. In my practice, I feel about 50% postoperative patients in 2 weeks have SIADH at some level. Luckily, most of them will recover over time, but you want to watch out for that very carefully. Postoperative seizures. We often get the question, and I'm sure Dr. Wong has had that question as well, that never had a seizure, should I be on antiepileptics? Now, if you look at the American Academy if you look at the guidelines, essentially states that patients who have never had seizures in the postoperative period, it's hard to define what we mean by that postoperative period. Most generally say within 2 weeks to 3 months, you're safe to discontinue antiepileptics as long as the patient has never had a seizure. But I caution that during that postoperative immediate period and when we start the process of other treatments, radiation, for instance, for high-grade gliomas, the risk of seizures is high during that time period. So I generally err on aiming towards 3 months instead of sooner. So we have to watch out for seizures. CSF leaks is an item that I feel that it's even in spite of good surgical technique, its risk still remains. And we'll see patients in clinics, and the family will say that there's some subcutaneous fluid. Luckily, it heals on its own. It's mostly because the bone healing is much more delayed, and the CSF leaks through that bone unhealed portions. Mostly, in most cases, it heals nicely, but you want to always worry about infections. I'm going to highlight at some time points about some of the clinical trials as well, and try to keep this 40 minutes we're going to spend together at the higher end of things, and trying to give you a little bit of a vision of what's coming down the pipeline and how the academic neuro-oncology community is not just sitting happy in what we have, but we're trying to advance the field and address complications. Also, there are a few areas that we must also keep an eye on, and there's good data now that essentially CSF dissemination can be promoted, or CSF spread of tumors can be promoted by surgical resections. Now, that does not mean that we not operate, but it means that we have to think about it. And especially in the arena of brain metastases, it's well known that about 30-35% cases, it's felt that you can have a CSF spread by surgical resection. Many patients in the postoperative period can have confusion, disorientation, sometimes effective anesthesia, sometimes it's effective tumor resection. And fortunately, most of those patients will improve over time. Pain control, as all of you know, always becomes an issue. And we always keep an eye out for anxiety and depression, and that's the thought that the whole person approach. Now, for many years when I trained, and I've been practicing for 15 years, looked at DVTs, and we often see it as something. If it happens, we're going to treat it, and for sure, that's the way to do it. Think about it, and always worry about it. The more you think about it, the more you will find this. Now, with a lot of the newer anticoagulants, there's an Alliance trial, which is an Alliance Foundation trial. And if some of you go to the Alliance meetings, there are basically two different categories. There are the regular Alliance trials, which most of the subsites can be a part of. We're not a full Alliance member. We're seeking to become a full Alliance member. But then there are Alliance Foundation trials. The difference is that most Alliance Foundation trials are better funded. So we all know in our neuro-oncology or clinical trials research, not just neuro-oncology, a lot of the consortia, generally the funding per patient is not as good as some of the other trials. But the foundation trials, if you're a full Alliance member, there is more funding for those patients. So this is an Alliance Foundation trial, which is looking at some of the direct oral drugs, anticoagulants, versus the heparins plus minus essentially using Coumadin. So this trial is open currently, and if any one of you are in a site where you're a full Alliance member, you could take advantage of this trial. And I'm sure your accrual will be good. And I'm hoping to be a part of this trial soon as well. I was recently at another essentially conference about a week ago, and there's a concept trial which is looking at the CSF dissemination. It's highlighting the point that I mentioned before, that we have to be cognizant of this fact that tumor resection can lead to CSF spread. And this trial is a very interesting concept. I'm sure all of you will find this a little bit counterintuitive, that the promotion is for solid tumor brain metastases. And a little bit of the backdrop story is that we felt that with solid tumor brain mets resections, there is a higher incidence of CSF spread, or at least it's felt there's a higher incidence of CSF spread after surgical resection. And folks on the other side of the table promote perhaps we should not resect and do radiation like CyberKnife or stereotactic radiosurgery or whole brain radiation. So a trial was proposed, which is still in the pipeline, but it'll be open soon, looking at pre-surgical radiosurgery. So the trial is good for up to 5 brain metastases, and the eligibility criteria are that 1 metastasis is large enough to warrant surgery, but it's still small size enough to come under the perspective of doing radiosurgery. So essentially, out of those up to 5 lesions, the larger lesion will have pre-surgical radiosurgery, and then within 3 to 5 days, it's going to be resected. And the whole idea is that if we can pre-surgically radiate that area and hit that all the microscopic disease around the resection margin, we might minimize the risk of essentially spread of tumor cells. So when I was at this conference last week, there's a lot of discussion about this trial, and seems like it might be open. Counterintuitive, because that's not what we practice right now. Right now, standard of care is you resect the dominant area, and then you do radiosurgery if you can, or you do more forms of XRT if you have to. So the NRG 1605, and you may want to keep an eye out for this. Now, from that perspective of surgical complications, there's also many radiation complications. And probably the most immediate are inflammatory changes in vasogenic edema. Not only that aggressive brain tumors invoke vasogenic edema, but radiation and therapies also invoke vasogenic edema. So that's something that you want to be very cautious about. All of you see patients in your clinic. If you treat patients with tumors of the brain, generally we like to keep them on some steroids. We're aware of the toxicities of steroids and how we always try to minimize it, but at least some amount of steroids is very helpful to essentially address that inflammatory changes. During radiation, I mentioned before, seizures are very common. Even in patients who've never had seizures before, during radiation, there could be high risk for seizures. Now, there's also a syndrome of acute radiation toxicity. And of interest, I had a patient that I saw in the hospital just recently who, during the second last fraction of radiotherapy, had acute encephalopathy. We thought about the usuals, metabolic, infectious encephalopathy. We thought of seizures, admitted the patient for a few days, but then we omitted the last 2 fractions of the radiation, steroids, hydration. 10 days in the hospital, she improved. So she had a classic acute radiation injury syndrome. Now, these are not common. I would say every year you will probably see 2 to 5. So they're not common syndromes, but it's something that we not think about too much. So worry about acute radiation toxicity. Essentially, pseudoprogression is a big issue. And I want to spend some time speaking about pseudoprogression. Remember, when I was training, we would speak of pseudoprogression only in lights of GBMs or high-grade gliomas. But now there's a true entity that you can see pseudoprogression essentially all tumor types. And now with immunotherapies, we're seeing pseudoprogressions elsewhere in the body, but the neuro-oncology arena has been soul-searching about pseudoprogression for many, many years. So I want you to keep your horizon very broad, that the old classic definition of pseudoprogression only happens in GBMs and high-grade gliomas is not entirely true anymore. You can see pseudoprogression with low-grade gliomas and with other tumor types as well. Late delayed toxicity, most of it, as you know, we worry about from radiotherapy, especially whole brain radiation, we worry about cognitive deficit. That's also a big issue, and there's a lot of enthusiasm in the community to address that. And hence, a lot of neuro-oncology clinical trials, if you're part of them, you'll see that there's always a cognitive endpoint, and there's a lot of fancy neurocognitive tests. If you're a clinical trials coordinator or an investigator, you'll have to go through that very detailed orientation and certification for neurocognitive testings. Currently, I do all neurocognitive testings. It takes about 45 minutes. And I'm trying to convince my research staff to get trained. They're holding me away, they're pushing me away so far, but I'm trying to hope that some of our research nurses will get certified. But if you're involved with CNS trials, this is something that is going to happen more and more. Radiation fatigue is very common, lack of appetite as well. Again, with radiation, mostly non-obstructive hydrocephalus. I want to mention that because time and time again, I've been seeing that in my practice, that hydrocephalus is an item you must think about and we often forget. Depression, psychiatric manifestations, and also heme abnormalities. It's well known that radiotherapy, now, of course, systemic therapies much more often, but even in the realm of essentially radiotherapies, we often see that you can see heme abnormalities. My general practice is that I see patients back in my clinic. They're getting high-grade glioma radiation, for instance. Every 2 weeks I follow them and I'll check lab work every 2 weeks. Now, granted, some of them are on systemic therapy, but I've seen heme abnormalities even with just essentially receiving radiation. Pseudoprogression, again, very deceptive. I want you to be aware of that and worry about it. Now, generally, all of you are right. It's the first few months from receiving radiation, but I'm trying to highlight things here today that you may not think about commonly. There's also a well-known entity of delayed pseudoprogression or delayed radiotherapy-induced changes, and that's what we also want to worry about. Now, as I mentioned, when you think about pseudoprogression, not only think about GBMs, which is where it's been promoted mostly, but also think about low-grade gliomas and CNS metastases. And other tumor types, actually medulloblastomas. At Moffitt, had a distinct case of a medulloblastoma, posterior fossa. We radiated and had increasing enhancement. We re-resected, it came back to be necrosis. So what that was really essentially pseudoprogression. So you can see pseudoprogression with other tumor types. Now, apart from surgically sampling, which probably would be the gold standard, there are some ways or some tools we have that we can try to decipher between true tumor progression versus pseudoprogression. MR perfusion and MR spectroscopy. Actually, many clinical trials, and Dr. Wong would know as well, or some of you who treat tumors of the brain, and Dr. Botero, that many clinical trials are actually requiring us to do MR spectroscopy and perfusion. Unfortunately, insurance always comes into play, and most hospitals that are doing MR perfusion and standard platform on their MRIs are not getting reimbursed for it. It's just software. If your radiology program is, receptive and they'll do it, that's fantastic. I think it can be very helpful. In pseudoprogression, obviously you'll see lack of perfusion, and spectroscopy data will be very suggestive that it's not tumor progression versus inflammatory changes. The brain PET scans, and it depends on your facility. When I was up at Moffitt, our radiologists were very pro MR perfusion and spectroscopy. Now, when I moved to another institution, they favored actually brain PET scans, but cost PET scan would be obviously more expensive, but on brain PET scans, you'll see hypometabolism and necrosis. Now, the sensitivity of both of these tests is 75 to 85% average, so nothing will be 100%, so you have to couple it with your clinical suspicion, timelines where the patient is, and of course, if push comes to shove, then surgical sampling might become important. Why does pseudoprogression happen? It's basically vascular. It's a vascular issue, and essentially there's leakiness of the blood vessels that gets created by radiation and systemic therapy, and hence there's fluid leakage and there's contrast leakage, and MRI is very limited. Contrast MRI is very limited in detecting inflammatory changes versus true tumor progression. Now, I always find very important to look at a slide like this and to give you guys an idea, even though the most classic form of pseudoprogression will be between that 8 to 16 weeks after radiation, but you can easily see it anywhere from up to 20 to 44 weeks after, and even much more delayed. And most of you who treat CNS metastases will know that often post-SRS, you can see necrosis up to 2 to 3 years out. And we have surgically proven that, and you'll see cases in your practice. So keep an eye out for that. And why is it important? Well, one of the important elements are that, let's say, for example, you have a patient on a novel drug that might be that individualized oncology. That's good drug for that patient, and you don't want to remove a patient from an experimental trial or a good adjuvant treatment that's working unnecessarily when the true reality is it was just necrosis and necrotic changes. So it's very important to essentially pick that up. Now, again, in spirit of highlighting some of the pipeline and some of the future entities that are coming down, coming down the pike, there is an alliance trial that just opened recently that's called as the BEST trial, so Bev steroids BEST trial, which is the alliance A221208. And there was data published out of MD Anderson, Dr. Victor Levin, many years ago that looked at Avastin and pseudoprogression, and they felt that using bevacizumab could actually help the healing process of inflammatory changes. But it was never studied in an experimental trial model. Some of us were giving Bev for these patients if we could get it approved, but it was never looked at. So finally, there's a trial which is looking at CNS metastasis. So this is for non-hemorrhagic CNS metastasis. So all those solid tumors like melanoma and renal cell will not be included because of the Bev risk of intracerebral hemorrhage. And so non-hemorrhagic CNS metastasis that post-SRS, your suspicion is necrosis, you'll give Bev plus steroids versus placebo and steroids. It's a double-blinded placebo-controlled trial, so the other arm will receive sham infusions every 2 weeks. So it might be a tough trial to accrue because of those sham infusions, but the whole philosophy is that Bev might reduce the need for long-term steroids. So those patients who are post-SRS necrosis may require steroids and succumb to the toxicity of steroids, but if you add Bev, you might be able to get them off steroids quickly. This trial is open at our site, and we're actively screening. If you're an Alliance member or even an Alliance subsite, it's not an Alliance Foundation trial, so even if you are an Alliance subsite like we are, you could open this trial. Cognitive changes, very, very critical. I highlighted earlier that almost one of the secondary or primary endpoints of most neuro-oncology clinical trials have a cognitive impact there, or there's an endpoint of essentially cognition, and hence those neurocognitive testings. There's another NRG trial, which was the meeting that we were at last weekend, which is looking at essentially hippocampal avoidance. I don't know if some of you or most of you have heard about that. There's been data published over the years of looking at brain metastases with whole brain radiation, and we often wonder, what if we did hippocampal sparing? And as most of you know, who remember your anatomy, that hippocampi are really your banks, patients' banks of memory banks, and it's been reported that hippocampal sparing could put forth to the patient the benefit of less neurocognitive impact, but it's never been looked at in a categorical fashion. And here we're trying to answer two questions that Namenda, which is one of the memory medicines, that all patients who are going to receive whole brain radiation. These are not the candidates for SRS. Now these patients could have had SRS before and they failed and now require whole brain radiation. So they'll essentially have whole brain radiation with this memory agent, memantine, which we use very commonly, with or without hippocampal avoidance. So there are several endpoints, but two of the most critical endpoints are neurocognitive change, plus we want to see what if we don't do, or what if we do hippocampal avoidance, And does the cognitive impact really change, but does local regional recurrence increase? So that's been the whole caveat about not sparing the hippocampi, that what if there's recurrence in those areas? So the best outcome would be that hippocampal avoidance does not lead to increased local recurrence, and adding memantine improves their cognitive impact. So the trial is open. It's a phase 3 trial. We have it open at our site. We're actively accruing, and if you're an NRG site, you could enroll in this trial. So the NRG CC001. This is just opened just recently, is an accompanying NRG trial, which is looking at small cell lung cancers requiring PCI. So as most of you know, with small cell lung tumors that have not had brain metastasis, all of you at your programs will give them PCI, so prophylactic cranial radiation. So the same philosophy, except that it doesn't have the drug involved, in which looking at hippocampal avoidance versus non-hippocampal avoidance and giving whole brain radiation. It's a phase 2, phase 3 trial. It recently opened. I was up at the NRG meeting last week. There's a lot of hype about this. We're in process of opening this trial soon at our site. So again, if you're an NRG site, you could open this trial today. Shift gears once more. Cancer-related fatigue. Very common, not just from radiation, but also from systemic therapies as well. And again, in spirit of that fact that we often used to put these things to the side. Oh, well, you're tired. Well, what can you do? You've had radiation. We're fighting cancer. It is what it is. There is an alliance trial, which is first of its only kind. And as most of you have used agents like this, and is looking at an agent in more of an experimental trial. Most of these agents are not approved for cancer-related fatigue, and they're very expensive drugs, and often you'll prescribe them off-label and you almost never get them approved. And this is an alliance trial that's been open for quite a while, and it still has several slots left, and it's looking at this novel agent, placebo-controlled. It's a 3-arm trial, 2 to 3 randomization. 2 arms will get active agent at 2 dosages, 150 and 250. 1 arm will be sham drug. Again, if you're a line site, the trial could be open. So trying to improve cancer fatigue. I will take some blame that there are systemic complications, or there are some neurotoxicity from systemic therapies, and you guys know these very well. I'm going to skip through some slides for the sake of time. Heme abnormalities, liver, renal, others. We watch that very carefully, and then also, as all of you know, with the immunotherapies and this immunotherapy arena evolving, and this could take 20 minutes in itself, but I'm going to brush on it very briefly. That you want to watch out for immunotherapy-related, very unique side effects that we're seeing, and pneumonitis, endocrine side effects, pancreatitis, hepatitis, skin abnormalities, and cognitive changes, of course, as well. Now, there are now. We should. It's only fair to speak about experimental drugs, as not only that the systemic and the common chemotherapies, we are all very good about treating those side effects, but there's also unique side effects that we are now noticing from novel new drugs. As good as these drugs might be, but they might have some novel changes. Now, this is a trial that is an RTOG Foundation trial. Again, just like the alliance within like the NRG, which was the old RTOG, as you know, also has 2 segments: regular RTOG studies and RTOG Foundation trials. The same issue, it's a small boys club, if you will, and there's more funding involved. So there's a trial looking at ABT414, which is an EGFR targeted agent. It's a monoclonal antibody drug conjugate for newly diagnosed glioblastomas. And the trial is open. It's one of the new hot drugs, and we have this trial open at our site for new GBMs. But it has a very high incidence of a very unique corneal changes. So these patients on protocol require a neuro-ophthalmology and ophthalmology evaluation pre-study and during study. So these patients, they develop this corneal side effect of the drug. It's an IV drug. And they complain of corneal abrasions, irritation, and some decline in their vision, essentially. Now, luckily, it's reversible. When the drug is discontinued, it goes away. It's kind of interesting that there's a way of minimizing that by putting cold packs on the eye. So that's, small microvascular eye vascular supply the cold ice packs. Usually the first 12 hours of the drug infusion, that is the highest side effect. You put cold packs and minimize the blood flow to the cornea, it minimizes that essentially side effect. But luckily it is reversible. So just to give you an idea that some of the new drugs, we are excited about it, but there might be some new toxicity potentials that we have to be careful about as well. Proton beam therapy, all of you, we can't go through our clinics one day or can't go through an hour of clinic without hearing about, proton beam therapy. Is protons versus photons, what's better, and is there essentially any essential benefit? So as all of you know, and the whole concept is that protons are essentially heavier particles, so their fall off is faster. So you can minimize the risk to essentially surrounding tissue. But of course, sites that have protons promote it, sites that don't have protons may not promote it. But it's never been looked at or until recently, it's never been looked at in experimental trials. Now, within the pediatric literature, and Dr. Botero can essentially comment on that, within the pediatric literature, there's good data with pediatric optic gliomas, for instance, optic nerve close proximity pathway tumors, that protons are superior. But outside the pediatric literature, there's no class 1, even class 2 evidence of using protons. We use it because we think it's a good thing, but it's never been proven to be that way. So there's a lot of very exciting new trials in the CNS tumor section arena that are coming up looking at protons versus photons. And I'm going to highlight a few trials. I'm going to toggle through these slides very quickly. There's an RTOG trial, which is for newly diagnosed glioblastomas, and it's a four-arm trial. I like to call it a four-arm trial because it's not only comparing glioblastoma treatment photons versus protons, but it's also comparing two different doses of protons versus photons. As you know, conventional dose for GBM is 60 gray, 55 to 60 gray, most will say 60 gray, but both arms, photon, proton, is going to subcategorize into two each arms thereafter, and it'll be 60 gray versus hyperfractionated 75 gray. So it's not only looking at protons are superior versus photons or not, but looking at whether a higher dose. There's good European literature that states that you can easily go up to, not easily, but you can easily go up to 75 gray and maybe get better local tumor control. So it's an exciting trial. And even if you're not a proton site, so that's a good element there. Even if you're not a proton site, you could open the trial, you could be on like the photon arm. Disclosure, the photon arm closed recently. So if you're not a proton site, you can't be on the trial. We were part of it. We screened a few, but we're not a proton site as of yet. Now, on the same token, because we've essentially recognized, and one of the main reasons of using protons is twofold. One, better tumor control, if it actually happens, and then essentially neurocognitive impact. Can we minimize neurocognitive impact? We're also thinking about low-grade gliomas to see if protons versus photons. Now, this trial is open, and if you're not a proton site, you could be part of the trial because the photon arm is currently open. So it's basically randomizing those high-risk low-grade gliomas. Now, you may ask me, what are the high-risk low-grade gliomas? The classic RTOG platform states is based on tumor size, so 6 centimeters or greater. If tumor is more of an astrocytic, tumor biology, age over 40, ECOG status greater than 2, tumors which the T2 flare abnormality crosses the midline or approaches the midline. If you have 3 out of those 5 criteria, you are slated as being high risk. So for high risk low-grade gliomas, protons versus photons. Atypical meningiomas, this is a trial I just heard about last week at like the NRG meeting. They had a little bit of a kickoff of this trial. It's the RTOG BN003, which is looking at atypical meningiomas. Again, the endpoint, is not only tumor control, but side effects and toxicity. So often if you come from MD Anderson published a lot of data for Simpson grade 1 to 3 resections. What that really means simply for good resections is Simpson grade goes between 1 to 5, and the 4 5s are pretty much those that have residual disease. You will have to radiate those. They're atypicals. But those that are very well resected, Simpson grade 1 to 3, the MD Anderson guys promote don't do radiation, watch them. Might make some sense, but the NCCN guidelines state do radiation. So this is going to answer the question whether we do radiation or we essentially delay radiation for later. So the trial is open, just opened last week, and if you're an RTOG site, you're more than welcome to. So I'm going to shift gears just a couple of minutes. I thought I may run out of time, but Dr. Santos really wanted me to talk about some of the immune-mediated syndromes, which under the element of toxicity and side effects. Now, paraneoplastic syndromes are very interesting. Now, there are many things in medicine that eyes will not see what the mind does not know. So if you keep an eye out for this, you're going to start finding these cases. And there's probably a lot of patients in, neurology clinics or even in academic centers that are not being diagnosed because it has very florid signs and symptoms. Now, apart from the endocrine and derm effects and rheumatological heme, the neuro effects are what we're going to focus on mostly. Now, paraneoplastic limbic encephalitis, and Dr. Santos and I actually, the more we've been thinking about it over a little over 2 years, we've been together working. We've been finding a lot of cases that almost mimic a paraneoplastic limbic encephalitis. Now, often when you were training and it's proposed you'll see a T2 flare abnormality, not always will you see that. So you want to keep your index of suspicion. Most patients will present with encephalopathy and seizures. So if you see that in a patient, and some of the most common tumor types are GYN oncology malignancies and lung cancers, especially small cell lung cancers. And so if the patient fits the whole idea of having a tumor type that is known for paraneoplasias and plus signs and symptoms, you want to be very careful. Now, there are many antibodies, so I don't know if your site locally tests those antibodies. Our site doesn't, so we send it out to an outside lab. And every 6 months, a new antibody comes on the market. So they're very hard to keep an eye on. If you work with the Mayo Clinic, they'll send you a card every 6 months to a year of the new antibody panel. So honestly, we just send it out to the Mayo Clinic and let them test it with a lot of antibodies. Now I'm going to quickly go through, because I'm over time now, a lot of the cerebellar degeneration, paraneoplastic cerebellar degeneration, anti-Yo, anti-TR antibodies, and ovarian carcinomas are very common to do this. Breast and lung cancer and lymphomas can also do this. Encephalomyelitis, which is pretty much a limbic encephalitis, is an encephalomyelitis, which is basically autoimmune inflammatory changes of the CNS itself. And there are several antibodies, anti-HU, anti-CRMP5, MA2, and you can get that panel, and they'll basically cover everything. When you get these panels, you'll see, negative, negative, negative. You just flip through the pages, and you'll see a positive at the end, and that's what you're going to treat. There are several other syndromes. There are paraneoplastic encephalitis with NMDA receptors, stiff person syndrome. Now, there's a non-oncology stiff person syndrome, which is anti-GAD antibodies. This is a different stiff person syndrome. Is more from paraneoplastic antibodies. So patients will present with periodic episodes of stiffness and almost cramping. It may not be the classic stiff person lying on the bed straight, but they'll present with cramping. And if you think of these syndromes, you will actually find them in your clinic. Opsoclonus myoclonus, opsoclonus ataxia, sensory neuropathy, very painful neuropathies. Had a patient in clinic with small cell lung cancer, presented with neuropathy that was thought to be chemotherapy induced, but lo and behold, a paraneoplastic panel was positive. So you want to keep an eye out for this. Now, a lot of the neuromuscular syndromes can also happen from paraneoplasias, Lambert-Eaton myasthenic syndromes, myasthenia gravis, and then also muscle injury, polymyositis, etc. Treatment of these tumor types, and this is my last slide, so thank you, Dr. Sands, for allowing me some extra minutes. The treatment of paraneoplasias, the old famous teaching was you treat the tumor itself, and that stands true. You treat the tumor itself, and the antibodies will wash out. But there are some therapies, meanwhile, as you're giving hopefully successful treatments, that you can give. Some of the anticholinesterase inhibitors, which are the drugs we give for myasthenia gravis, can be used. IVIG, which is more of washing out the antibodies, something that I very commonly use. And sometimes while patients are waiting with ovarian carcinomas to get that response, you can start IVIG and wash out the antibodies. Plasmapheresis, I usually start with IVIG. There's no data to say plasma better than IVIG. I think patients tolerate IVIG a little bit better, just my opinion. That if that doesn't work, then plasmapheresis can be tried. Immunosuppressants can help sometimes as well. But paraneoplasias is something to think about. So I wanted to cover a few elements. I know I jogged you through a lot of distance here, but it gives you an idea that there's another side of oncology, of not just amazing effective treatments that we're going to talk about over the next few days, but what toxicities are the secondary impact that phone call you get every night, as I quoted earlier, that there's a toxicity. We have to treat both. We have to play both fields at the same time. And if we keep these things in mind, our patients will do a lot better. Thank you for your patience, and we'll stop there.